Hi and welcome to Great Expectations. Today is Ask the Doctor, which is our monthly open line for you to ask our doctors any mum or baby related questions. And ahead of World Malaria Day this Saturday, the 25th of April, we've decided to get the ball rolling this morning with a focus on this disease. So, how serious is malaria? Well, it kills about 1 million people per year, most of whom are in Africa. And to put that into perspective for you, HIV/AIDS claims about 2.5 million lives a year globally and TB 1.9. To tell us more, we're joined by GP and Rosebank Travel Clinic doctor, Dr. Samantha Fee, and Dr. George Gabriel, who's the regional medical advisor at the Netcare Travel Clinic. With them are paediatrician Dr. Simon Strawn and gynecologist Dr. Daniel Mahapa. Welcome. George, how many people are infected with malaria in Africa and specifically in South Africa?
There are about 300 million cases of malaria from WHO, of which 90% occur in Africa, carrying most of the burden of malaria. In South Africa, the stats we have from 2008, there were 6,600 cases with about 50 to 60 deaths.
So it's ongoing and it's
prolific. It's a big burden of disease for the planet.
Sam, are there certain areas where malaria is more prone to happen?
Definitely. The mosquitoes like heat, so they like temperatures around 30 degrees centigrade. They also like quite a lot of humidity, ideally around 60%. They don't like to be too high, so we tend to find mosquitoes below 2,000 meters above sea level. And geographically, if you look at the areas in the world, this really equates to the subtropics and tropics. Africa, most of Asia, Central and South America.
So for such a picky little insect, it does an awful lot of damage.
It does.
Specifically in South Africa, where is the malaria area?
Predominantly, and obviously this varies season to season, northwest.
Okay.
So we're looking at it all along the Mozambican border, and then creeping inwards towards the Hazy View, Kruger Park areas, down to Richards Bay, Umtunzini, Cozy Bay, Sodwana.
George, how do you contract malaria?
Well, basically, it's a mosquito bite. Mosquitoes are infected by Plasmodium, which is the parasite that it lives within the mosquito. When the mosquito feeds on a human blood, and that's typically the female mosquito, she will transmit the parasite to the human. The parasite then undergoes a very complex life cycle, both in the liver and in the blood. And then during its life cycle, it causes illness. And that's when we see the complications of malaria.
And will you see it immediately? How long after a mosquito bite will symptoms arise?
Look, the textbooks will tell you typically, 12 to 14 days, but there have been many cases where it can take up to 3 months before you can display symptoms of malaria. And again, depending on the strain. So when you take a history, it's important to work out, has it been 12, 14 days? But that is not a hard and fast rule. People can get malaria symptoms within 5 days and up to 3 months after leaving a zone.
Sam, what are the symptoms of malaria? Because from what I've read, it looks like it starts like the common cold.
Well, it does, and the word symptom means what the patient themselves are feeling. And typically they present with a flu-like illness. The very well-known signs and symptoms are high fevers, which can initially be unrelenting, but then can become quite episodic. They can have sweating. They can have flu-like bony aches, chills and rigors. They are feeling very tired and unwell. And that typically is what we are presented with if we get it in an earlier stage. Obviously then as the disease progresses, they can become more and more unwell with other symptoms of confusion, delirium, convulsions, problems with the liver, problems with the kidneys.
And it's only one type of mosquito that will give you malaria, or am I wrong about that?
It is. It's a mosquito called the Anopheles mosquito, which is the one that transmits malaria. And there are different forms of malaria, all of which can form slightly different clinical pictures. But yes, you're absolutely right. It is the female Anopheles mosquito.
Simon, let's turn to children and malaria, because I remember being told when I was pregnant that, number one, a pregnant woman doesn't go into a malaria area, which we'll discuss later, Daniel, but also that you don't take a child into a malaria area under the age of 5. Is that an urban myth, or would you go with that?
No, I'd definitely go with that. I think that the important thing about malaria in children is don't mess with it. Because children don't necessarily present the same way as adults do.
Why?
Because these kind of feverish illnesses in children are so common. Children get fevers at the drop of a hat. And malaria can present just like any other feverish illness. Plus, the child's not going to be able to come and tell you 24 hours before the fever starts, I'm feeling terrible. All you're going to be presented with is a sick child who's got a fever. They may have diarrhea. They may have a snotty nose. There's nothing that suggests that this is malaria. So that's the first issue. And the second, so the important thing there is that parents who have been into a malaria area with their children need to advise the doctor that they've had that travel in the last 3 months.
So is that what you would use then? If you were going to be diagnosing malaria in a child, what would you look for?
I think about, this is absolute honesty, I think about malaria every single time I see a child with a high fever.
Really?
And I ask the parents, have you traveled anywhere? Because if that child has malaria and that child's under 5, specifically under 3 years of age, they don't get sick slowly. They get sick very quickly, and they get complicated malaria very, very quickly. So yeah, if you are going to be going to a malaria endemic area like the Mozambique coast in December with your 18-month-old, I would say don't do that.
Okay.
In fact, don't take a child under 5 there. If you are going to be going to somewhere in South Africa's boundaries, to, say, the southern area of the Kruger Park, and it's the dead middle of winter, well, maybe if the child's 4 or 5 years of age, then we can start debating that. But the advice really is, when you have a young child, have a holiday somewhere else. Choose somewhere where there isn't that risk.
There's lots of places like
Yeah.
that. Daniel, for a pregnant woman, is it safe for a pregnant woman to go into a malaria area?
It is absolutely not safe to go into malaria area if you're pregnant, more especially if you come out of an area which is not malaria endemic, because you have got no resistance against malaria. And with the physiological changes that happen in pregnancy, the absorption is poor. Even if you have to be given what you call prophylaxis, the absorption is going to be poor. And most pregnant women, they vomit, and the side effects of those prophylaxis are quite intolerable. So it's just advisable that you don't go into a malaria area if you are pregnant, because the effect of malaria on pregnancy affects both the mother and the baby. It causes a lot of anemia due to red cell destruction that my friend have said, and pregnancy itself is an anemic condition. It has hemodilution. So in that case, the effect on the baby become irreversible. So it's better advisable that the mother shouldn't go into malaria area.
If a mother does go into, or rather if a mother lives in a malaria area and is pregnant, what can she do to prevent herself getting malaria? Because the reality is some people do live in these areas and they do fall pregnant.
If you're living in the malaria area and you have no choice,
Yes.
there are quite a few strategies that one could implement. The first is to get an insecticide-treated bed net, and you put that over the bed. The second strategy is to make sure that you spray the home or the dwelling with residual spraying that stays on the wall. And DDT is not popular and is not liked, but it does work. And in fact, we had a lot of malaria cases in 2000, up to 60,000 cases. Now we're down to 6. And the only reason why we're down to 6 is because of the effect of DDT and Department of Health stepping in and doing in-house residual spraying. So it does work. So if you don't have a choice and you're going to live in a malaria area for a prolonged period of time, insecticide-treated bed nets, as well as in-house residual spraying. Those are important.
Can you take prophylaxis as a pregnant woman?
You may, but there's nothing safe from the first trimester. So you're in a bit of a pickle there. Thereafter, there are certain options to you. But if you prevent the mosquito bite, you're probably curtailing 25 to 30% of transmission of malaria in a malaria endemic area. Yeah.
If a mother, Daniel, is pregnant, goes to a malaria area and contracts malaria, what can happen?
What can happen, it can be many, besides the illness itself that the mother might suffer. What could happen disastrous to the baby is that those babies, they don't grow very well, because the parasite circulating in the bloodstream, it also enters the placenta, which is the organ that feeds the baby and excretes all the baby excreta. So it is called what you call placental insufficient, poor placental function, which results in that the baby doesn't grow well. Or either the baby may die. If it's before 20 weeks, the baby may abort, or it commonly to cause intrauterine fetal death, or even premature birth on the baby's side. On the maternal side, the effect is more this maternal anemia, which is not reversible even by iron supplementation, because the parasite actually destroys the red blood cells.
If you're planning a holiday and you're worried about malaria, we'll be running a contacts crawler across your screen this morning. Now stay with us. After the break, we look at the best ways of preventing this disease. You can call us on 011 537 9332 or SMS us on 34970. Hi, you're with us on Great Expectations, and today is Ask the Doctor. We're taking your questions to our doctors. We've been chatting to travel clinic doctors George Gabriel and Samantha Fee, and gynecologist Daniel Mahapa, and paediatrician Simon Strawn. If you've got a question for our doctors, you can call us on 011 537 9332, or you can SMS us to 34970. Before we get on to the more general questions, there's just a few things I'd like to wrap up. In terms of anti-malarial drugs, is it true that those drugs are mosquito resistant, or mosquitoes are resistant to those drugs? They don't work on all mosquitoes.
No. You're talking about the drugs that we give for prophylaxis
Yes.
are to treat and prevent Plasmodium infection. That's the parasite. So there is parasite resistance. So the old Daramil and Paladrine we no longer use because it's only about 35-40% effective. It's not good enough to
Is that the
prescribe.
one your parents used to make you take? The taste
Correct,
filthy?
the bitter ones, yeah.
Yes.
The newer drugs, there are issues with resistance, not as bad as the Daramil and Paladrine, still recommended, but no drug is 100% foolproof. No drug is foolproof. If you're talking about mosquito, the mosquito is also resistant to the insecticides that we're using. So that too is an issue. So we've got a dual problem, malaria resistance or Plasmodium resistance, as well as mosquito resistance. So you've got to tackle it on two fronts.
If you have to go into a malaria area with your children, can they take anti-malarial drugs?
Absolutely. And it becomes a risk-benefit analysis. So
Sometimes there is no choice.
Sometimes there is no choice. And if it is truly a malaria area and you're entering with small children, then you would look at it very, very carefully. And I think there a consultation with your pediatrician or a travel medicine specific doctor is useful. It's a big ask to figure it out on the spur of the moment. It's age related and weight related, what we would use for children. And obviously then also taking into account their past medical history, any other medications they may or may not be on, any family history that may influence one or other drug choice.
If you take anti-malarials, does it mask the symptoms of malaria itself? We've had a few SMSs from people saying apparently if you do take the anti-malarials, sometimes they don't work, and even then they can actually make it worse.
I think once first off is a myth. If you have malaria and you're taking an anti-malarial, and you are astute and your doctor's astute to put their malaria as part of the diagnosis, you would need to send some blood off and specifically look for malaria parasite infecting a red blood cell. We call it a ring-formed trophozoid within the red blood cell, and you specifically look for that sign. So if you feel as are out there and you're sensitive to the diagnosis of malaria, you will pick it up. And the fact that you're taking anti-malarial will not make the diagnosis harder. And I think that's a myth.
Samantha, if you're going to go to a malaria area, you come back, you're feeling tired, a bit fatigued, at what point would you go to the doctor and check if you had malaria? What symptom would it be for you that would say, this is not a cold, this is not just flu?
I think for me it wouldn't be the symptom, it would be the fact that I had been in a malaria area. And as George mentioned, there is a textbook incubation period, but we've all seen cases on either side of that. So for me it is more, hi, I'm feeling slightly flu, I'm sure it's a basic virus, but 9 days ago I was in Mozambique. So for me that's the lesson. Don't wait until you've got bone-crushing chills, a roaring headache that feels like your head's going to split, and are almost unable to drive yourself to the doctor.
When we're preventing ourselves being bitten by either the Anopheles mosquito or any mosquito really, there is a question that comes up regularly, and that is mosquito coils, those mosquito burning mats, are they safe to be used in children's rooms? Are they safe for us?
I think there's relatively safe. But again, I don't think there's enough evidence in the literature to say yes or no. But I think what we do know is preparations like DEET are far more effective as a personal protective measure that you will put onto yourself.
What is DEET?
The exact name I couldn't tell you, but it's an insecticide or a repellent.
So where would you find it? Because
products like Tabard, common products like that will contain different concentrations of DEET, and you've got to watch that concentration. You'd like to be at least between 3 and 10% concentration of DEET to have it effective. We would not recommend things like citronella and lavender.
Simon, would you use that on a child's skin?
Yeah, I would.
Would you?
Yes, I would. Because there's not much else you can do. I think the point has been made. Citronella doesn't work.
Yes.
I think that children should be sleeping under mosquito nets. I think that burning anything in a child's room is a little dangerous. If you're going to be putting a mosquito coil on, so you've never done it before, and you're 300 kilometers from your nearest medical help, and your child has some kind of respiratory problem, I wouldn't fumigate the air with stuff like that.
Okay.
That's going to burn the whole night in the child's room. But certainly to apply something with DEET on, like Tabard, If you put it on a child's body where the child can't get its mouth to, like this part of the arm and down the back and behind the legs, on the soles of the feet, it's fine.
So it's actually only dangerous if you ingest it?
Well, it's just it tastes ugly. I think that if you are going somewhere and you're applying it continuously through the day, through the night, applying it many times, yeah, anything like that is potentially dangerous. But if you're applying it specifically for the purpose for the 7 days that you've gone to this malaria area because you've had to go, and that's what you're using, no, that's not going to be dangerous to the child.
One thing to remember, which I'd like to add on here, is the Anopheles is a feed at particular times of day. So you're looking at dusk and dawn, and I think that's the time you need to focus the applications. Between dusk and dawn. Its feeding habits have been well described. 1 or 2 exceptions, but we know it's a dusk and dawn feeder, and that's why the advice of long trousers at night, long sleeves at night, that advice is sound. So anything you could use to barrier yourself against the mosquito bite is going a long way into preventing malaria.
Anzel's on the line from Nelspruit. Hi, Anzel.
Hi.
What can we help you with?
I would just like to find out, I'm going to Mozambique this weekend, and I did speak to my pediatrician. He gave me a malaria tablet for my 20-month-old baby to drink. So I would just like to find out, I heard that this tablet only prevents the symptoms, but it suppresses the symptoms, but it doesn't prevent the child getting malaria. Is it advisable giving the malaria tablet to him, or shouldn't I do that?
Interesting question. Samantha, would you feel that?
I think firstly, Anzel, at the risk of ruining a happy and already planned weekend away,
Yes.
I think all of us on the panel here would advise that you don't take your 18-month-old into Mozambique, but let's assume that that is unavoidable. Do you know what the tablet is that your doctor prescribed? Malinil.
Yes, Malinil.
Now, Malinil is recently registered in this country for pediatric use for children over the age of 10 kilograms, over the weight of 10 kilograms. So this for us is very exciting news. It is a well-known and effective malaria preventative medication.
Okay.
But as we've said as well, nothing is 100% foolproof. Categorically, I would advise if you're taking your 18-month-old into Mozambique that according to their weight, you give them the medication.
Okay.
All right. Okay.
There you go, Anzel.
Okay. Thank
Good
you very
luck.
much.
No worries.
Okay.
And
Bye.
Bye-bye. An SMS here. 3 months ago, I went on holiday to Durban. Last week, I got sick. It seems like flu, but I'm not getting better. Could this be malaria? That's from Famida. Malaria in Durban. We have seen cases.
Yeah, the entity is called airport malaria. So
nice.
The mosquito travels either in luggage, in a taxi, whatever. And we find malaria being diagnosed in areas that are not malaria. Also, we've got a lot of people moving in and out of malaria areas, especially Mozambique, Malawi, Zambia. And they come across into our borders, get bitten by Anopheles, and then that mosquito will then transmit onto somebody else. So if somebody's not getting well and they're having high fevers, a malaria test will be a prudent test. We had 2 cases in Heidelberg, in fact, where these people had not travelled anywhere, 2 brothers, and were diagnosed with malaria with a positive smear. And it was postulated that the mosquito came along either in a suitcase or in a taxi. Provided the temperature is right, provided the humidity is right for that mosquito, it will survive 7 to 10 days.
For a tiny little thing like that, they seem extremely...
Yeah.
To take it slightly further, there was a case where a young student in London died of malaria, had not left the United Kingdom, had been studying for exams, but his roommate had been backpacking through Africa and had returned with a backpack, and the only reason that they could find was that the malaria-carrying mosquito had survived a transatlantic flight.
That's unbelievable.
And it wasn't thought of. So, he died undiagnosed.
We're back after the break with more happy news when we take your calls on any mummy or baby related questions. Call us 011 537 9332 or SMS us on 34970. Today's Ask the Doctor, we've been hearing about malaria and its effects on expectant mums and babies. Our doctors, paediatrician Dr. Simon Strawn, gynecologist Dr. Daniel Mahapa, travel clinic Dr. Samantha Fee and George Gabriel. So if you have any health concerns, now's your chance to get dialing on 011 537 9332 or you can SMS your comments to 34970. An SMS here, since birth my 9-month-old baby girl gets blue around her eyes, nose and mouth. What is that? From Samantha. Simon. A blue tinge around your eyes, nose and mouth.
Probably nothing.
Okay.
Probably nothing other than the child's colour. Mm-hmm. If you are blue from a lack of oxygen, which I understand where the question comes from, is that you have to look at the tongue
Okay.
and the colour of the lips and the nail beds. And
Okay.
if those are nice and pink, then that's not from lack of oxygen. The kind of bluish
Tinge.
shiners, this kind of darkness that children get under their eyes,
Yes.
is very often due to allergy from nasal congestion. So children who are always snotty and congested, sneezy and rubbing their nose, and this what we call nasal salute, those children very often have bluish around underneath their eyes. Certainly in smaller babies, you can see a bit of blue tinge around their mouth, which is absolutely nothing to be concerned about. Some children have very prominent veins along the bridge of their nose
Yes.
and along the side of their eyes, which is also... But, hey, if everything else about the child is completely fine and the child is growing well and not a sickly child, I would say, well, that's just the child's colour. But if none of that is... Yeah, if you're worried about the child, rather have the child
Go to
checked
the
out.
doctor. Daniel, an email here from Irene Britz. She says, I had a cesarean with my son. He's now 9 weeks old. I was only in the hospital for 1 day. After 3 hours after the operation, I was walking around and I went home. I didn't rest much and I didn't have a lot of pain. I had my first period at 6 weeks and bled heavily, and then it stopped. And a week after that, I started bleeding, and then it stopped again. And it's been going on like that since then. Sometimes I bleed very heavily. Other times it's just like the starting of a period. Is this normal or not? And what should I do?
That's strange, that's not normal. At 6 weeks, it's normal to start having periods after 6 weeks, because 6 weeks after birth, physiologically, involution has taken place. You are back to non-pregnant state physiologically. But bleeding that comes and go, which is related to a cesarean section, which is a surgical procedure, there are several differentials you can look at which one should go and examine and exclude. Firstly, she has been cut on the uterus and sutured. When you cut, some blood vessels have been cut there and resutured. There might be, when the stitches absorb, some of the bigger blood vessels might just open, and the ones that are bleeding and stopping and bleeding. Actually, you might think it's bleeding and stopping, while it's continuous bleeding into the womb until the cervix open, and it closes again, and cervix open. Or the other thing that could be excluded by ultrasound, which is easier way, is if one of the cotyledons of the placenta is not there inside, causing erosion around that area, which keeps on the endometrium, the layer of the uterus that lines the uterus, doesn't form nicely there. I think